Good afternoon and welcome. Thank you for joining us today. My name is Samantha, and I'm the Director of Member and Partner Services for the Texas Association of ACOs. We are excited for this opportunity to present to you our next installment of our webinar series, High Needs Meets High Performance, Achieving the Quintuple Aim. Sorry about that. Before we get started, I'd like to share a few quick notes to help you make the most of your webinar. For audio, if you're currently listening through your computer speakers and prefer to dial in by phone, simply click the small up arrow next to the microphone icon in the bottom left corner of your Zoom window. Select Switch to Phone Audio and follow the dial-in instructions provided. We welcome your thoughts and questions throughout this session. You can submit questions anytime by clicking the Q&A icon on your Zoom toolbar. Just type the questions there and we'll be collecting them along the way and addressing as many as we can during our Q&A portion at the end of the webinar. Feel free to use the chat box if you're having any technical difficulties. Also, today's session is being recorded and will be shared with you following this webinar. With that, I'm going to turn the presentation over to Stacy. Stacy?
Thank you, Sam. Hi, everyone. Thanks to Sam and to Tacos for having us. We're thrilled to be here. And to those of you joining live or catching the recording later, thanks for making time to join us. Today, we're going to dive into one of the most important conversations in value-based care, how to support high needs populations while still driving high performance and achieving the quintuple aim. Caring for high needs populations, as we all know, is complex, can be messy, and the stakes are high, but it's also where the impact can be the greatest. So today we'll talk about how to make it easier with smarter data and sharper tools. We can turn the complexity into meaningful outcomes at scale. So my name is Stacy Fox. I am the SVP of Market Development and Growth here at the Garage. Jessica, I'll hand it over to you.
Hi, good afternoon, everyone. My name is Jessica Robinson. I'm the Chief Platform Officer with the Garage.
Thank you. And Darcy?
Hello, my name is Darcy Shepard. I'm the CEO of Middletown Medical. It's nice to meet everyone.
Great, thank you. So let's start with what we're going to explore together today. This is our high-level agenda. We're going to walk you through the journey into the why, the how, and the real world impact of empowering high needs populations. So first, we'll start with a quick introduction and a look at who the Garage is. For those of you who may be new to learning about us, we'll talk about our commitment to the quintuple aim, and then our data first, digital first framework for identifying and managing these high cost, high needs populations. And then Darcy will go into a powerful case study with Middletown Medical, kind of showing how this all comes to life in practice. And then lastly, we'll talk about and look into our platform strategy and architecture that enables these smarter, faster decisions. And then we'll wrap with some Q&A. So please feel free to put those questions in so that we can make sure that we address them towards the end. Our goal is for you to leave with actionable takeaways and inspiration to bring back to your teams. So before we get into the how, I want to start by quickly telling you more about who the Garage is and our mission and framework that drives our platform. So we are the most comprehensive platform empowering value-based care across communities. We are committed to the quintuple aim of bettering care, lowering costs, improving health outcomes, sustainable care models, and true health equity. We started this journey over 13 years ago, the day the first ACOs were formed. And today we partner with over 140 organizations, including 40 ACOs, FQHCs, IPAs, clinically integrated networks, home health groups, health systems, and payers, truly anybody empowering healthcare and value-based care across the country. So our mission is to change healthcare for good, one community at a time. Our framework brings all of this together with advanced analytics, care coordination, and care management risk and performance management, giving you a 360-degree view into each patient journey. So at the center of all of it is data. You'll hear Jessica talk a lot about our digital first, data first approach. That is by design. Our platform powers over 14 integrated applications across these, different key framework dimensions that you see here today. But in the back, we bring in all of the clinical data from our customers, claims data, and social data to power all these different applications. So today we've connected bidirectionally to over 127 EHRs and about 80% of the payers. We also have deep partnerships to bring in additional clinical claims, social determinants of health, and lab data through partnerships with Health Gorilla, LabCorp, and Experian to give you that complete real-time view of your population. So at the end of the day, it's all about delivering the right data at the right time to the right person so that care teams can act, not just react. So whether you're working to improve care transitions, close care gaps, manage chronic diseases, or reduce costs, we turn that data into action to drive change. Now that you've gotten a feel for who we are and kind of what drives us, I'm going to hand it over to Jessica, who is our go-to expert in designing these care models that work for our high needs populations. So she's going to break down how we identify and engage the 5% of the patients who often account for 50% of costs. JR, go ahead and take it away.
Thanks, Stacy. So when we talk about identifying our high needs population, we want, from a platform perspective at the Garage, we went and looked at it from what we heard from each of our clients. So everything within the Bridge application and the Bridge platform and every application within that has been curated working directly with clients like Darcy and others. So when we looked at understanding how do our clients see a high need patient, it does vary depending on the type of population that the organizations are working with, but this seemed to be kind of a starting point to where we were getting a good commonality across groups. So if you look across the circle under advanced analytics, we're looking at patients that have a behavioral or substance use diagnosis. We also work with substance abuse centers and taking in their discharge data so that we can work with the hospitals and making sure that that care continuum is cool. Disability, tier 3 patients. These are going to be patients that are not only high utilizers, but we're seeing kind of maybe additional excessive use of the ER rather than coming into the provider's office. Multiple chronic conditions. Again, some of those patients can be extremely well managed, whereas others are not. So making sure that those patients hit not only multiple chronic conditions, but also see additional parameters that kind of put them into that category. Patients with an extremely high risk score. We know that they're clinically ill, but again, are they managed and where do they fall on the risk stratification line? We also want to understand where patients are that have not had a PCP visit in the last 12 months. We know that as patients are experiencing chronic conditions such as cardiovascular issues or pulmonary, they may be seeing those specialists more often, and some of their primary care is happening in those offices as well. However, we want to ensure that that PCP understands who those patients are and kind of brings everybody and kind of brings all the care coordination together and ensures that their care team is kind of coordinating and making sure everyone is kind of on par for success. Patients who are dual eligible. We know that if they're in the Medicare or the Medicaid bracket, we know that they are eligible for certain services and usually are going to be part of this type of a grouping. We also look at social determinants of health. We want to look at identifying if patients are positive or have a Z code or a diagnosis or an indicator that they are at a high or medium risk for food insecurity and or housing instability. These are key factors, especially for patients in the dual eligible population, where it's possible that they're making decisions on whether or not they're buying food or getting their medications, or they have transport to get to those appointments. So really understanding where this circle is and understanding how does all of this kind of match together with the overall patient scope. The last one we look at is patients with more than 6 active medications. Again, Clinically, as the care teams are looking at these patient charts, they're identifying whether or not they're controlled, whether they're at not necessarily risk, but whether they're controlled and or need additional care management services. So kind of bringing all of these pieces together, identifying that eligibility criteria for possible patients that are in high needs, and then allowing for the care management team to really clinically review those charts and make sure that these are appropriate patients for overall care management. Now, as I mentioned, everything you see on the right-hand side are going to be applications within our overall Bridge platform. So each of these was designed and kind of curated working directly with our clients across ACOs, across MSOs, IPAs, the list of clients that we've worked with that Stacy had mentioned. The biggest thing is understanding the data. What is the data telling us? What is that clinical data telling us? What is that utilization telling us? What are those cost variables telling us? And where do we see the need to intervene? For example, patients who have high ER visit rates, we want to make sure that we bring them in to our care management flows so that they can be part of kind of that, our primary care office world, rather than just using those really expensive services as their primary care office. So we want to bring those in, kind of understand how that data hits. From a care management perspective, being able to create a relationship with someone at the practice, at the patient level that they can build trust and they feel comfortable with, we tend to get more information. They're going to come and see us or call their care manager prior to maybe utilizing urgent care or ER services. Ideally, if there's an exacerbation of any of those conditions, we want to ensure that they're talking to their care management team, and that's really enabled via our grid application for care management. We also know that at the patient level, there's going to be patient engagement. So patients need to be part of that journey as well. So having a patient engagement tool that ties with care management allows those communications to be seamless, allows for that interaction of the patient to feel like they're involved in their overall care, and just kind of creating a more nurturing environment for them to be positive and to have that successful outcome from a care management perspective. Quality compliance, care managers wear all the hats across the board. We want to make sure that they have all the information they need. Are they following up on mammography screenings that maybe never got scheduled? Patients that need additional testing or need to come in and make appointments for HC serial validation or care gap compliance. Again, care managers and coordinators are kind of all together across the board. So having access to quality measures and the care gaps that those patients are eligible for is huge. Now, the bottom two right screenshots that you'll see, one is the point of care and Care Copilot. What we have found is that providers, whether you're nurse practitioners, physicians, MAs, practice administrators, everybody has so much data that they're looking through and really trying to understand and grasp that sometimes it's like, just tell me what I need to know. So what we look at is, we call that our tiny tasty morsels. So we package the information, all of the analytics, all of the care management pieces, all of the scorecarding details, the KPIs, bringing all of that together at the point of care. So when you're at the office with the patient in the room, or pulling up the patient chart and having a conversation with them over the phone via telehealth, you are quickly able to see what are the 5 or 6 things that are important for me to address with this patient, in addition to the reason why they're being seen. So that really helps kind of clean up the need to dig through data and all of the alerts and notifications that come through with some of those pieces, and kind of putting it all into one place tied to that patient record, seamlessly available at the point of care. Now, care management. We know that care managers are extremely important in the overall healthcare continuum. We need to ensure that care managers and all of the care team are essentially successful in what they're looking to do. And so what we wanted to do is bring in Care Copilot. So Care Copilot is identifying how can we enable additional outreach and actions for care team participants for their patients. So as we look at patients who are discharged, automatically creating that notification for getting those patients back into our fold, making sure that we can outreach to those patients, and so they're seen for that transitional care management, and at a minimum, getting those patients into those medication reconciliation phone calls, whether those are done in the office or over the phone, making sure that those are happening so we're reducing any unnecessary readmission, any additional exacerbation of illness, and making sure those patients kind of stay in the healthy frame of mind as they move forward. Next, Stacy.
Thanks, Jessica. That was great. And I agree. I think a key point that you brought up is really focusing on the data based on the user. So for the care team, making sure that we are populating what they need to know to manage the care of the patient versus the providers being able to just see the data they need while they're seeing the patient at that time. So I think it's a perfect example of not just surfacing the risk, but activating those insights in real time so care teams know what to do and when. Now we're going to hand it over to Darcy to take us through how this looks in practice, from data to care delivery to repeatable outcomes.
Yes, hello, everybody. I apologize. I've been traveling and unfortunately I'm sort of stuck between places. I'm Darcy Shepherd. I'm the CEO of Middletown Medical. We are a multi-specialty group. We have we see about 100 unique patients annually and have about 63,000 attributed lives that are involved in some level of value-based care. About 33,000 of them in some type of shared savings or a risk arrangement. We've been with the Garage for about 5 years, close to 6 actually. And I'd like to tell you a little bit about our journey. So I joined the practice about 10 years ago. And at that time, we were not at all engaged in value-based. Our only step into any type of advanced payment arrangement was CPC Plus. And even that was not well received by our physicians. My goal when I joined the practice was to actually move us along the value-based path. I come from a payer background and I understand the need to be able to take care of patients wherever they are and meet their needs as much as possible. We started with the Garage with simply looking for one payer agnostic platform through which we could manage the gaps in care. But once we started doing that, we realized how much more could be done. So we started speaking with payers about getting claims data sent in. They were resistant at first because we are a single TIN multi-specialty group, although we do operate more like a SIN. A large portion of our patients are a population in need. So we have between Medicare and Medicaid, that's about 68% of our population. And within that scope, about 20% of those are dual eligibles with multiple chronic conditions. We began about 7 years ago to try to work with payers directly. And when I met the folks at the Garage, I realized that accumulating all this data gave us power to help our patients in ways that we never thought we could before. At this point, I believe we're getting data from about 9 of our patients, including Medicare. With all that data comes power. We've used the Garage for our care management opportunities. We've used it for patient outreach, all the things obviously listed on the slide. But what that really means to us is that we can help our patients in multiple ways. Our doctors can not only treat their medical concerns, but they have a team around them that can help these patients, break through some of the roadblocks to care that they were facing, because we know all about them. We treat although it's population health, we treat each patient as if they are an individual person, individual needs. And with all of this data, we're able to actually see everything that they're dealing with. And we believe we're doing the best job possible to take care of our patients. Let me give you a little insight into the care management function that we're using. So with the data that we're receiving, we're able to stratify our patients very easily. We know those patients that are high utilizers, we know those patients that are no utilizers, and we know those patients that are attempting to engage in their own care, but there's something in the way, whether it is social determinant of health that's getting in the way, whether it's a mental health condition that's getting in the way, or maybe it's just their medical conditions are just overwhelming for them. We're able to stratify these patients and give them exactly the resources that they need to have the best outcomes. Our doctors feel empowered to know when that patient walks in the door that, one, they're not alone in treating them. They have a team of case managers that are there to help the patients along the way. They have the data behind them to know exactly what's happening with their patient instead of just what the patient reports. And the patients feel, I believe, very comforted to know that we know that much about them and that we want to take care of all of them, not just their medical needs. Obviously, the care gaps are easy. People not easy to close, but certainly easy to know that they're there. The care management function, as I said, allows us to stratify our patient outreach. We use the Garage as communicator for a lot of patient outreach. This is an easy way to connect with patients without really interrupting their day too much. It's a simple HIPAA compliant text just to check on them on a daily basis, or to remind them of an appointment, or to see if they're having any issues in getting to that appointment. And then we have remote patient monitoring for those patients that need some support at home. And we have found through remote patient monitoring that our ED utilization rates have dropped dramatically. And one story I do like to tell is that we had a woman who was close to 90 who had just lost her husband. And while he was with her, she managed her hypertension and COPD just fine. She didn't panic when something happened. She just came to the doctor when the time came. But once he passed away, she became very fearful. And so every time there was a twinge, every time she was concerned, she wound up in the emergency room. Her biggest fear was always that she would wind up being admitted and never go home. When we introduced her to remote patient monitoring, and she knew that there was somebody there watching, somebody there to lend a hand if she needed it, she calmed down completely, and she has not had an ED visit since then. She's actually doing very well. Another example of where this care management and remote patient monitoring was very beneficial was a woman who we realized was missing most of her appointments because she was embarrassed to come in when there were too many patients in the building. She was embarrassed, she said, because she was in a wheelchair. She's a rather large woman, and she felt that the arrangements that had to be made to get her into a room she didn't want to do that in front of people. We realized that by scheduling her appointments when it was earlier in the day or later in the afternoon, made her more comfortable. She then was compliant with her appointments. She engaged with remote patient monitoring, so she also was not just calling the ambulance every time something came up. And she too has done much better. The Garage team has supported us through every step of this value-based journey. My practice, even though we're a single TIN multi-specialty group, we grew by having other practices join us, and each of those practices had their own protocols, their own processes, and their own opinions on where we should be with value-based. And with the Garage team, we were able to meet each of these providers where they were and get them engaged in a way that they felt like they were part of the solution and that it wasn't some administrator telling them exactly what they needed to do. I can't say enough about our journey with the Garage.
Thanks, Darcy. Definitely appreciate the real world stories too. I feel like I could listen to those literally all day long. At the end of the day, hearing how all of this data, insights, action, analytics, and tools are impacting the patient. That's the real journey that gives me chills a little bit, to be honest, but love how you tied it all into bringing in RPM, the data, and at the end of the day, you were reducing, unnecessary acute utilization or ED visits, but it's the impact on the patient and their well-being that is really meaningful.
Exactly.
Yeah, that's great. I love how you frame that. So with that, I'm going to hand it back to Jessica. Appreciate that, Darcy, and feel free to jump in here while Jessica's talking too, if you want to highlight any additional stories or impacts. But Jessica, back to you to go deeper into our tech and how it makes all of what Darcy was talking about possible.
Thanks, Stacey. Just you kind of piggybacking what Darcy just said is at the end of the day, at the end of the workflow, at the end of everything we do here at the Garage within the Bridge platform, there's a patient whose life is impacted, whether it's because we gave information to the care team, whether it's we gave information directly to the patient. And we really keep that responsibility very high when we're looking at everything that we do and how we go about our job every day. So I too love hearing those patient-centric stories. They make everything kind of a little bit more real sometimes. So I want to explain a little bit about what we see on this slide here. This is how we look across the Bridge platform from not only a strategy perspective, and kind of where do we want to go, how do we want to do it, as well as from an architecture, what are we looking at, and how do we want to have all of that data kind of organized. So we look on the left-hand side of the page, you're going to see eligibility and screening. This is where we're taking in those algorithms, identifying those high-need patients, identifying those patients who are eligible for RPM services, patients who are not having those PCP visits within 12 months or every 12 months, patients that have been identified across the data sets that we are able to ingest for food insecurity or high need for access to medication or even access to care. So looking at the data sets that we receive, one of them being Experian Health, where we're receiving the SDOH data, we're able to identify patients across the need continuum on SDOH before some of the providers even have that information. And depending on how much information a patient wants to tell their provider. Sometimes when we're able to kind of share that information with the team, they're able to address that in the office a little bit differently rather than just kind of answering questions. And in some cases, patients aren't comfortable talking about that information. So that's a big piece that we present to our providers at the point of care. Care managers have access to that information as well, because again, sometimes over the phone or a video call, it's a little bit different type of conversation that you feel comfortable having. Same thing with LabCorp. We get data from LabCorp across all of the labs that a patient has. So we're able to, again, provide information that's happening at specialist office. Health Gorilla data, this gives a larger access to data that is not necessarily limited or siloed to kind of where they live, where they reside. We have a lot of snowbirds. Snowbirds might not be well, and they might have high CCCs, and they might be high need, but they're also traveling during the winter months down to the south. So allowing for any of those details, if there's a catastrophic event, patient ends up in the hospital or in the emergency room, being able to notify Darcy's team, any of our primary care office team, that the patient was admitted, helps for that continuity of care. In some instances, it may be that provider is able to call the facility and provide additional information about the patient that they may not have. Providing information directly from the Bridge application, giving that information directly to the patient so they can share that. So as we integrate all of that data, we're kind of aggregating it together and everything's essentially sitting in our data vault. So that's where we run the algorithms, identify where they fit across the care continuum from a high need perspective, what are the care management programs that are available, and then we look at, okay, where do they need to go? What are the types of interventions or monitoring programs that are available that the patient fits into? Allowing for not only at that time patients to be kind of compartmentalized into these areas, but also at aggregate level. So anytime a care manager has access to a patient record, the entire care team is going to have access to that same visibility. So if a patient has an SDOH referral that's pending and being sent out, the care manager for the disease is also being aware of that social intervention. Behavioral health, being able to refer out to behavioral health when items or assessments are updated, making sure that the care team as a whole understands what those changes are or what those needs are. So again, having that transparency of the patient record across the data really helps for us at the garage to be able to kind of create those tiny tasty morsels. And that's the row you see right above the Bridge logo, which is going to be Grid, Containers, Communicator, Blaze Speaks, and Copilot. So what we're looking to do is, as we scrub all of this data, how do we identify patients? How do we trigger or identify what interventions or monitoring programs need to be associated to the patient. We suggest those to the care team. In Middletown's case, we put that into their containers view. So everybody that has access to those patients based on their schedule, they will see all of the care programs that a patient is eligible for and be able to enroll them into any of those appropriate. As the care management team starts to get involved, they have access to that entire patient chart and all of that data. And then they're communicating back and forth with the providers as needed as well. So we're able to kind of take all the information and say, here's your list of patients. Then when we talk about patients from a communication perspective, as Darcy mentioned, being able to easily communicate to patients via text, giving them an update on a closure, maybe of an office, or giving them information or reminding them to bring certain things to the appointment today, helps everybody, kind of feel like that patient's really part of that process. So it's really important for that communication to be available. It's also bi-directional, right? So in some cases, patients are responding back. We don't want those responses to kind of go into a black hole. I know that, when we receive some messages from third parties, you may want to respond and go, wait, what is this? But you can't. It says don't reply. So you can't really follow up, and then it's forgetting to ask the question. So making sure that they can have those synchronous communications is also very important. Play speaks at the point of care, making sure, again, those tiny tasty morsels are provided to the providers as patients are seen in the office or during a telehealth virtual visit, making sure that they have that information so they can make that appointment as comprehensive as possible. Co-pilot. Co-pilot is essentially kind of the care management agent. How do we streamline and automate some of the care management workflows for those care managers and make sure that they have access to the most recent information? How do we identify and maybe create campaigns directly to those patients, or notify those patients of their calls coming up in the next hour so that they make sure they're available for the phone call or for the video call? So making sure across the board that all of the users, practice, patients, care teams within kind of the Bridge ecosystem have access to all that information. That's going to be key for that patient outreach. Now, when we look on the right side, that's going to where we're looking at kind of the analysis and the productivity. So how does this impact the outcome? How does the co-pilot activity increase care management outreach? How does patients that are screened for RPM, how does that impact their overall care processes as they go through the care management journey? Are we seeing those improvements or those additional engagement, just as Darcy had mentioned? Patients that are identified as having a need, that's when we can start making accommodations and seeing how can we help them become more comfortable, or how can we ensure that they are coming to their visits, and making some of those arrangements that probably weren't easy right on day one or week one, but as you plan ahead, you can really start to make some additional accommodations. And then you're starting to see how those patients are improving over time. So not only are we tracking the interventions that are happening, the categorization or the eligibility criteria of patients from kind of the advanced analytics perspective and identifying where do we see the changes across that patient population, we're also looking at what are the changes and what is the data that's coming and needs to go back to providers at the point of care EHR. We also learn we also have other users coming in, such as teams from social work, where social work may not be available in the offices. We have access to be able to have those social workers be referred from the system and be able to come directly into Bridge and work those patient records as needed. Same thing for behavioral health. So nutrition, pharmacy management. So really understanding that, as we have this set of data, we have patients, that information that need to be acted on. So how can we enable the care continuum, the care process, all that care team to have access to that information, see what's working and what's not working, make sure that they can make those decisions, and really at the end of the day, target that high need population so that they can become better managed and healthier as they continue through their health journey. Thanks, Stacey.
Darcy, I saw you may be unmuted. Did you want to add something?
Oh, no, sorry, I was just listening. Sorry.
Okay, no worries. Well, thank you. Thanks, Jessica. I think at the end of the day, you highlighted a lot of the core functionality needed to manage the high needs populations. As you can see, there's a lot of data that goes into the platform. We have over 3 petabytes of data. So it's important that that data is also displayed for the right user at the right time for the right purpose. So making sure that we're not overwhelming the care teams or the providers, but giving them just those tiny bits and pieces of actionable data so that they can give the best care to the patient. A little more kind of stats about the garage here. I did mention the impact that we've had with our ACOs, but we have over 40 ACO customers, so very familiar with managing these high needs populations. And we know that every ACO is unique. We know that every journey is unique. So everything that Jessica talked about is very customizable and adaptable to each of our partners and customers that we work with. So we essentially will work to set up what we call as North Star measures and metrics, but to make sure that we are populating the right data for you and kind of measuring those key metrics that mean and matter the most to you based on what your goals are. So to date, we've saved our ACO customers over $1 billion in gross savings across the last 7 years. We have an average over 90% quality score. You'll see 15 million lives and about 25,000 physicians on the platform. So making sure that you get, that data displayed just for the physician at the point of care via, some of those tiny tasty morsels or the Blaze Speaks that Jessica mentioned. So with that, we definitely appreciate your guys' time. Hopefully you guys have some questions, but wanted to thank you for your time and your energy today. We'd love to open it up for questions and keep the conversation going.
All right, we'll go ahead and get started, Stacy. First question we have today is, what's the best way a platform can integrate and normalize data from multiple sources and ensure accuracy and usability for care teams?
Such a great question, Samantha. I'll hand that one over to Jessica.
Thank you. So when we aggregate the data, we're taking the data in its rawest form, as raw as possible in some cases, and making sure that that gets normalized into our data warehouse. So we have a standard data warehouse that we're mapping all of that data in. That's going to be the data vault that we had on the last slide. We're going to bring all of that data in, and then we do sometimes have conversations with the clients to make sure that there's no variance and they're clear on where they're at from the data integration perspective. Pushing all of that data to the front end and creating that longitudinal patient record that everyone has access to. So that's going to aggregate all of the data, bring that information in, understand that it's normalized, it's going to map and be available in our data vault. We also provide the data vault access to a lot of our clients so that they can go in and they can run audits, or they can even run their own reports if there's anything that they want to see outside of the platform. In some cases, we are kind of seeing how do we want to identify a different population. Some of our team are very data heavy. They want to run in and kind of create that grouping and see what that count of patient is. So at the end of the day, bringing all of that data together is seamless. We have to ensure there's data quality. We are understanding that data accuracy is key. We need to make sure that at the end of the day, as that data gets integrated in the data vault, we are running all types of quality assurance tests on it, making sure that we're checking and essentially validating data from the front end of our system all the way back to the source data as it goes through the different layers within the data vault.
Thank you, Jessica. We do have one of our attendees for the webinar that raised their hand to talk. So I'm going to allow Andrea to ask her question directly.
Thank you.
Andrea, you should be able to talk now.
I see that Addison was added. Sam, did you add Andrea also?
I did. I clicked both of them by accident. So let's try again. Okay. Because they keep popping up. So let's see here. Did that work that time?
Yes. Hello.
Andrea, okay.
Yeah.
Perfect.
Hi, Stacy and Jessica. Thanks so much, and Darcy, for the time today. As you all think about sort of the next phases of sort of innovation and growth here for your platform, curious to understand kind of what types of innovation you all have planned for the next 2, 3, 5+ years, and how you all may be incorporating the latest agentic AI and LLM models into your thinking as you approach the next phases of innovation here.
Great question, Andrea. We are looking at how can we ensure that the information is presented to our clients with those tiny tasty morsels. So agentic AI is something we're already started with, Copilot being essentially the first version of that, and then aggregating and making sure that we're learning from that. So from a machine learning perspective, taking in all the feedback and the actions and allowing us to kind of create how we can present that information with the tiny tasty morsel element, as well as to indicate what's the outreach, what's the call to action, what is something that we can do on behalf of that user, whether they're a provider, whether they're an administrator, and being able to notify and kind of get that information out to the right people. So agentic AI is essentially how we're moving forward in the next 3 years. If we look at essentially, when you see the front end, all of the applications we saw, I think slide 3, that we have available within Bridge, my team, the platform team, we call ourselves a studio, we are looking at that essentially being the back end for all of the agents that we're looking to create. So we have different pathways that we're looking at, identifying how can we bring those in, and then bringing those into our learning models as well. It's a huge innovation process. Yes, we're excited about it.
Thank you, Andrea. All right, next question we have. How do you balance personalization and scalability when designing interventions for complex high-needs patients?
Yeah, great question. So from a care management perspective, we are providing within the system essentially kind of a standard care plan or care assessment pathway that care managers can start with. Now, with that being said, every care management program and team and client may approach their care management a little bit differently, but essentially we're all similarly doing the same work. So from that perspective, whether they're using a different type of care plan library, integrating what they have, integrating their assessments, their screening tools, adjusting the framework that we have within care management for the eligibility grouping, and kind of what are the assessments or screenings that are required from that. And even in some cases, automating those workflows back to the action. What is the action when we have a yes or no and this is a screening assessment? What is it yes or no when we have this suggestion of maybe a SDOH intervention? How can we kind of automate some of those follow-up pieces? Now, we also are providing access to the entire patient care team. So from a configuration perspective, we have the framework that can kind of tailor to any of the care management needs. As care management is taking on maybe acute level episodic type of care plan conditions or initiatives, we can track those separately and in tandem with the kind of the general disease-centric management, because at the end of the day, we want to ensure that everyone that has access to that patient record is going to see that patient-centric care plan along with their longitudinal record. So there's no gap in that transparency of information. So that's a really good question, but essentially we want to make sure that that data is kind of synergized, but allows for the flexibility. And the way that we've come about the architecture and kind of building that platform or that application within Bridge has really helped us to be able to make some of those tweaks and adjustments for each of the care team programs that we're working with.
If I can just jump in
Thanks,
for a second
Jessica.
from a practical standpoint. We use all this data that's obviously accessible to all the members of the care team as sort of a virtual huddle. My practice is we have 22 locations. We're in 3 different counties, and the care managers are not always with the providers, vice versa. And what we found is by having them all have the same access and they're having huddles right around the care management function on a daily basis. So it is an exceptional tool for us.
Thanks,
Great,
Darcy.
Darcy. Another question we did have is how quickly does it take to see an ROI?
That's a great question. We actually have a guaranteed ROI on the platform within 6 months, but majority of our customers are seeing ROI in that first 2 to 3 months. So you'll start to see, reduction in admit discharge transfers, kind of reduced unnecessary acute utilization, completions increased for annual wellness visits, Those are all guaranteed ROIs on the platform that you can see in just 60 to 90 days.
Thank you, Stacy. Another question we did have was, what's the average implementation time for Bridge, and how do you ensure minimal disruption during a rollout?
That's a great question. I'll take that. So when we're looking at our rollout, we have a lot of applications within Bridge that are available. And during the sales process, Stacy and her team do a great job of really understanding kind of what are the key pieces or key workflows that the client wants to essentially start with. From an integration perspective of data, we plan for essentially kind of a minimal viable version of the product, essentially at the minimum to be available within the first 90 days. That can be as expansive as data integrated from claims, payers, and starting EHR integration, or in some cases, depending on access to data that clients might have, just even a roster of lists that we can then submit to Health Gorilla and pull in that clinical data. So within the first 90 days for all of our clients on the ACO side, because we've been doing it for so long, we started with ACOs, as Stacy had mentioned. So we are now down to 30 days. So from an ACO's kind of standard setup, CCLF files, all of your alignment files, your ingestion, your benchmarking, that's going to all be set up and ready for you to start using within 30 days or less.
Okay, I think we have time for one more. So the last one that I did have for you today is, what does it take to build a sustainable culture of accountability around Quintuple Aim across clinical, operational, and executive teams?
That's a great question. I'd love to see if Darcy wanted to start, and then we can add anything to it.
From our standpoint, we started very slowly, and we, as I said before, we met people where they were. So some of our providers were very anxious to engage technology, engage new workflows, and they, of course, had this encourage their teams to do it, while others were a little slower, and they asked us to do more of a centralized approach where we had a team of care managers and quality people that were leading the charge for them and kind of holding their hand through the process. I would say across the practice, it took about 6 months to get everybody on board, but about 60% of the doctors joined and were ready to go right away. We monitor and provide reports. We have report cards built into the Garage to show them how they're doing as far as cost, as far as closing gaps, their annual wellness completion rate, and ED utilization. And then also we're pointing out constantly those patients that have been attributed to them that they haven't seen. So they're very engaged in what they're doing. But it was a process of getting them to understand why it was important as well, and to sort of move along the continuum at their own pace until they felt comfortable.
Stacy, Jessica, was there anything you wanted to add to that?
Yeah, sure. When we look at our North Star objectives, that was one of, I think, third or fourth slide, but essentially all of our North Star objectives are aligned to kind of a measure or a requirement across the Quintuple Aim. At the end of the day, we want to make sure that we are providing the information that's important for the overall team, regardless of what level of licensure those users are, at the executive level, the management level, so that they can kind of identify and then start to speak to the better outcomes, the reduction in cost, creating the visibility within the scorecard for the providers' KPIs that they can see at their leisure rather than waiting for kind of a meeting or report to come across. And what we found essentially is, as the providers started to get used to coming into Bridge, they were then a little bit more encouraging to their peers because they started to see the value. It's not always right away, and sometimes it takes a few months for everybody to kind of get on board, but having a couple providers or champions within the organization always helps. And I think they understand, you know, we understand with the platform that we're not trying to add additional work. We want to give you as much information without you having to dig for it or to do anything to get it. So that's kind of our tiny tasty morsel, you know, methodology across the board, no matter where we are, trying to give as much information at that view and that point of care as possible, while keeping the providers and keeping those care teams kind of where they do their normal daily work. And also, you know, calling out some of those things that maybe they didn't know, because we have additional data sources. That also helps us to kind of provide information that providers want to know and maybe didn't have access to due to various integration pieces. So giving them kind of the confidence to come to the system and see the clinically relevant data, the clinically relevant utilization data, and even their own KPIs helps them to have a better conversation with their peers and really see the impact of what a platform like Bridge can really do for them.
Great. Thank you, Jessica. Thank you, Stacey. Thank you, Darcy. We truly appreciate your expertise on this topic today. And thank you to everyone who has joined us for this information. As a follow-up, we'll be sending an email that includes the presenter's contact information should you have any additional questions, along with a link to the webinar recording. Please feel free to share that recording with your colleagues or peers who may find it valuable. We appreciate your participation today and encourage you to keep an eye out on your inbox for any future announcements or ongoing webinars. Thank you, everyone. Have a great day, and thank you to the Garage.
Thank you.
Yeah, thank you, everybody. Thanks for joining.
Bye-bye.